Welcome back to the Deep Dive. Today, we're doing something a little different. We are effectively trading in our usual comfortable studio vibes for, well, detective caps.
Or maybe surgical scrubs?
Honestly, probably a combination of both.
Yeah.
Because we are looking at a stack of documents that, it turns a standard medical checkup into a full-blown crime scene investigation.
It really is a fascinating shift in perspective. Usually when you think of the nose, you think of, allergies, colds, maybe a sinus infection.
Right, it's a nuisance.
Exactly, you grab a tissue and move on. But the material we're looking at today, this clinical checklist for diagnosing nasal masses, it treats the nose as a black box of really high-stakes information.
Yeah, exactly. It's not just, here's a spray for your stuffy nose. It's, tell me exactly where you work, how old you are, and does your head hurt when you tie your shoes? It turns out the nose is hiding secrets. We're talking about how doctors diagnose everything from harmless polyps to life-threatening tumors just by asking the right questions.
And that's the core of it. It's about pattern recognition. In medicine, especially with something as complex as the head and neck, you can't just look inside and know the answer.
It's too crowded in there.
It's way too crowded. You have to triangulate, you take the demographics, the type of discharge, the specific pain patterns, and you kind of overlay them until only one or two possibilities remain.
So let's unpack this. We have this checklist, and the very first thing that jumps out is how much weight is put on who the patient is. Before they even touch the patient, they're building a suspect profile.
Oh, absolutely. And age is the biggest filter.
Right.
Age is incredibly discriminatory in medicine, especially in this part of the body. If you look at the data, some conditions have very strict biological clocks. Take JNA, juvenile nasopharyngeal angiofibroma.
Okay.
The source material is so specific, it occurs almost exclusively in males between 10 and 25.
Exclusively is such a strong word in science. You usually hear mostly or.
In this case, biology is just that rigid. JNA is a vascular tumor, basically a mass of blood vessels. It's hormonal.
So if a 15-year-old boy walks in with a specific nasal mass and nosebleeds, JNA is the very top of your list. But if a 15-year-old girl walks in with similar symptoms,
You can rule it out.
almost immediately, you're looking for something else entirely. And that is a massive clue just from their age and gender.
That is wild. Biology just deciding, nope, only teenage boys for this one.
Right.
But then you have these other conditions with weird age spikes. The source mentions NPC nasopharyngeal carcinoma.
Right.
It has these bimodal peaks. Can you explain what that means?
Sure. A bimodal just means two modes or two peaks. So the data shows NPC spikes early, between 10 and 20 years old. Then the incidence drops off. It goes into a statistical valley.
Like you're 30, you're kind of in the clear.
Statistically speaking, yeah, you're in that valley. It then spikes again between 40 and 60. Olfactory neuroblastoma does something similar. It peaks at 20 and then again at 50.
So it's not just about getting old and things breaking down.
No, not at all. They often follow very specific developmental or, hormonal windows in the body. Speaking of getting old, though, the source does flag the 6th and 7th decades. So, people in their 50s and 60s as the danger zone for general sinonasal malignancy.
Yes, that's when the cumulative effects of life tend to show up. And that brings us to one of the most interesting Sherlock Holmes parts of this deep dive,
The patient's job.
their occupation.
This part blew my mind. You wouldn't think your job could determine what specifically grows inside your nose, but here we are. The source explicitly links the furniture industry to sinonasal malignancy.
It's the wood dust, hardwood dust specifically. And it's not just about sneezing because it's dusty. If you spend 40 years inhaling fine particulate matter from sanding wood,
It just sits in there.
it sits there. It settles in the ethmoid sinuses. Those are the honeycomb-like air cells right between your eyes, and it causes chronic inflammation. Over decades, it leads to a specific type of adenocarcinoma.
A classic occupational hazard.
Exactly. So if a patient says, I've been a cabinet maker for 30 years, the doctor's ears should perk up immediately.
And then there's the rice fields. If someone comes in and says, I work in a rice field or I live near the coast, the checklist points to something called rhinosporidiosis.
Which is a chronic granulomatous infection. It's caused by a pathogen that thrives in stagnant water.
Wow.
So just knowing someone is from a coastal region helps you differentiate between a scary tumor and, a treatable infection before you've even done a biopsy.
Okay, so we profiled the patient. Now we have to look at the scene of the crime, so to speak. We have to talk about discharge. And apologies to anyone eating lunch.
It is gross, I admit, but in this field, discharge is data. The character of what's coming out of the nose is one of the most reliable indicators of what is happening upstream.
The sourceless, watery discharge. My brain just goes to, well, they have a cold, but that's not always it, is it?
No, and this is a really high stakes distinction. Watery, yes, it could be allergies, but it could also be CSF rhinorrhea,
Cerebrospinal fluid.
brain fluid, leaking from the brain into the nose.
That is terrifying. Just brain fluid dripping out of your nose. How do you even tell the difference without a lab test?
There are bedside clues. CSF is usually crystal clear. It drips steadily when you lean forward, and oddly enough, it tastes salty or sweet.
Wow.
But the fact that it's even on the list shows why you can't be dismissive. You have to ask, is this snot or is this the fluid protecting my brain?
Then you have the unilateral rule, which is
Right.
one of those classic medical teaching points. The source makes this stark contrast. If a child comes in with unilateral, one-sided, foul-smelling, blood-stained discharge, what are you thinking?
A neglected foreign body. Basically, the kid stuck a bead, a pea, something up their nose 6 months ago and forgot about it.
And the parents just miss that.
Often, yeah, until it starts to smell. The object gets infected, you get that foul, bloody discharge. It's gross, but it's benign.
You just pull it out.
You pull the bead out, they're fine.
But, and this is the big but, if an elderly patient walks in with the exact same symptoms, unilateral, foul-smelling, bloody discharge,
You do not suspect a Lego? No. You suspect malignancy. In an adult, it usually means tissue is dying. A tumor has outstripped its blood supply and is becoming necrotic.
same symptom, totally different diagnosis. That's the triangulation you were talking about.
Precisely. Context is king. And we see this again with nasal obstruction. It's not enough to say, I can't breathe.
Right, the doctor needs to know how you can't breathe.
Yeah.
The source talks about obstruction during expiration versus inspiration,
Yeah, breathing out versus breathing in.
which seems like splitting hairs, but it tells you what kind of polyp you have.
It's about mechanics of ball valve effect. So the source notes that if the obstruction is worse when you breathe out, it suggests an antroconal polyp, an AC polyp.
Walk us through the physics of that.
Okay, so an AC polyp usually grows on a stalk from the maxillary sinus, the cheek sinus. It hangs back toward the throat. When you breathe out, the airflow pushes that polyp back and plugs the exit of the nose like a cork.
But when you breathe in, it moves away.
Exactly. Conversely, if the blockage is worse when you breathe in, it points more towards ethmoidal polyps, which hang down from the roof and get sucked into the airway.
Fascinating. And then there's the deviated septum trap. This felt like a warning to young doctors.
It is a massive pitfall. A deviated nasal septum is very common. Most of us have one. But the source warns that if you see bilateral obstruction, both sides blocked in elderly patient, do not just assume their nose is crooked.
Because a crooked septum usually only blocks one side.
Exactly. If the septum is pushed way over to the left, why is the right side blocked too? The source warns a malignant mass could be pushing it over.
So it looks like a deviation, but it's not.
Right. It's actually a tumor displacing the anatomy, and if you just go in to fix the septum,
You could cut right into a tumor.
or worse, leave the cancer growing behind it.
That's incredibly high stakes, which is why the next step is pain mapping. Because where it hurts tells you where the problem is.
Right, so let's look at this map. The source breaks it down by location. If I had a headache in the temporal region, the side of my head, what are we thinking?
The source suggests things like temporal arteritis or even TMJ jaw problems.
Usually not the nose itself.
Okay, what about the back of the head? Occipital pain.
That's often high blood pressure, or it could be isolated involvement of the sphenoid sinus. It's deep in the skull, and oddly, pain there refers to the back of the head.
And then there's the bending forward test. You drop your keys, bend over, and boom, pressure.
Right. If the headache gets worse when bending forward, the source lists two main suspects. First, sinusitis. Gravity shifts the infected fluid. That makes sense.
And the second one.
Raised ICT intracranial tension. High pressure inside the skull.
Which brings us back to that scary territory of, is this a nose problem or a brain problem?
And that line gets blurry. I mean, look at the list of differentials for just a swollen cheek. It's huge.
It is. On one hand, you have infected acne or a dental cyst.
Common stuff.
On the other, osteosarcoma bone cancer. And hidden in that list is a condition called fibrous dysplasia. The source highlights a very specific clue for this one.
The ground glass appearance on a CT scan.
Ground glass. That's such a vivid image.
It describes the texture of the bone as it's replaced by fibrous tissue. Normal bone looks solid white on a scan. Air looks black. This looks hazy, gritty.
Like ground glass.
Exactly. And the source notes this is common in females in their teens. So again, that demographic profile helps you sort through that massive list.
So we've talked to the patient, we've looked at their face, now we have to get hands-on. We're doing the probe test, and this sounds like a game of operation.
It's a very practical, tactile way to find out where a mass is coming from. You literally take a probe and try to pass it around the tumor. The source outlines these do not pass zones.
Okay, so if I can't pass the probe between the roof of the nose and the mass, what does that tell me?
It implies the mass is coming from the roof. So you're thinking olfactory neuroblastoma from the smell nerves, or even more critically, a meningocole.
Remind us what that is again.
It's a herniation of the brain's covering. Basically, a sac of brain fluid lining is hanging down into the nose.
So if you mistake that for a polyp and try to remove it,
You're creating a direct leak into the brain. You risk meningitis. That's why proving you can get above the mass is so important.
and if you can't pass the probe between the floor and the mass,
Then it's likely a rhinolith, which is a calcified stone.
there's also a warning here about the bleed test.
Oh yeah, if you probe it and it bleeds profusely, you stop immediately.
Why?
The source lists things like angiosarcoma or angiofibroma, vascular tumors. They're made of high pressure blood vessels. If you poke them too hard, you can cause a massive hemorrhage.
It's amazing how much information you can get just by seeing where a metal stick fits.
Yeah.
But the investigation doesn't stop at the nose. The source says to look at the eyes and ears. Why is a nose doctor looking at my eyelids?
Because it's all connected. The source mentions looking for a drooping eyelid. This can be a sign of Horner's syndrome.
Horner syndrome. How does a nose tumor cause that?
It's a domino effect. A tumor in the back of the nose spreads to lymph nodes deep in the neck.
Okay.
Those swollen nodes compress the cervical sympathetic chain, the nerves running through the neck, and those nerves control the muscle tone of the eyelid.
So tumor spreads to node crushes nerve, eyelid droops.
Exactly. A distant signal of a central problem.
Wow. And the ears.
If a mass in the nose gets big enough, it blocks the eustachian tube. That tube connects the nose to the middle ear. If it's blocked, you get fluid buildup serous otitis media, hearing loss.
So a patient comes in saying, I can't hear, and the problem is actually a tumor in their nose.
It happens.
There's also a term here, increased intracanthal distance, the eyes being pushed apart.
This creates what's sometimes called a frog face deformity. It suggests a long-standing, slow-growing issue, like polyps or a fungal infection.
Why long-standing?
Because fast-growing cancers tend to destroy bone, they eat through it. Slow-growing benign masses just push bone, they expand the facial skeleton over time.
That's a disturbing picture. The body just changing shape to accommodate this thing.
It is, and we see that with the jaw too. The source talks a lot about trismus.
The inability to open your mouth, they grade it from 1 to 4.
Grade 4 is complete closure, and the causes could be tetanus, or it could be a tumor invading the jaw muscles.
So if a patient has a nasal mass and suddenly can't open their mouth,
It suggests the tumor has broken out of the nasal cavity and is eating into the surrounding muscles.
there's also this symptom called nasal regurgitation, which is exactly what it sounds like.
Yeah, you drink water, and it comes out your nose. This happens when the seal between the mouth and nose is broken.
Like a cleft palate.
It could be structural, like a cleft, or it could be neurological. The tumor has paralyzed the nerves that lift the soft palate when you swallow.
It really emphasizes that the nose isn't an island. It's right in the middle of everything. Which leads us to the red flags. How do you know if the tumor has gone into the brain without a scan?
We touched on this with the headaches, but the history is key. The source says to ask about nausea, vomiting, and personality changes.
Personality changes from a sinus problem.
It's rare, but if a tumor pushes through the roof of the nose into the frontal lobes, it can affect behavior. A family member might say, he's just not himself lately. It's a major red flag.
Another one is anosmia, total loss of smell.
Which can happen because the tumor is blocking air to the olfactory area, or worse, it's actually destroyed the olfactory nerves.
Now, before we finish, the source drops some really specific safety tips. For example, about patients with asthma.
Yes, this is a practical pearl that saves lives. If you pack the nose to stop bleeding, it can trigger something called a nasopulmonary reflex.
What did it do?
It can trigger a bronchospasm, so you're trying to stop a nosebleed and you accidentally constrict their lungs.
That's a nightmare.
It is. And related to that, using beta blockers during surgery can also precipitate an asthma attack in these patients. It's a reminder you have to treat the whole person, not just the nose.
There's also a note about blood transfusions. Why is that relevant?
Historically, a history of multiple blood transfusions raises the risk of HIV, and an HIV infection can present as a lymphoma in the nasal cavity.
So a nasal mass could be the first sign of a systemic viral infection.
Correct. And that's why the source insists on a full systemic exam. You don't just look up the nose,
Yeah.
you check the abdomen, you listen to the lungs.
Right, looking for fluid in the belly or listening for crackles in the lungs.
Because that nasal mass might not be the primary problem, it it might be a metastasis, a spread from a liver or lung cancer, or the nasal cancer has spread to those organs.
It's all connected. We started this deep dive talking about a stuffy nose, and we ended up checking the liver, the brain, and asking about someone's job at a furniture factory.
That's the beauty of this kind of medical detective work. The nose acts like a canary in the coal mine. It gives you these signals.
And ignoring those signals can be disastrous.
Yeah.
I think the thing that sticks with me most is that contrast between the child and the elderly patient.
Yeah.
The exact same symptom, meaning something totally different just because of their age.
That's the context is king rule. You can't interpret a symptom in a vacuum. A deviated septum in a 20-year-old is a nuisance. A deviated septum that appears in a 70-year-old is a siren going off.
It really makes you appreciate the complexity of what these specialists do.
And hopefully, for anyone listening, it makes you pay a bit more attention to what your body is telling you. You know, not every headache is just stress.
Well, on that slightly hypochondria-inducing note, I think I'm going to go check my intercanthal distance in the mirror.
Just don't use a probe.
Deal. I'll leave that to the professionals. But I will be thinking about that grand glass appearance. It's such a haunting description for something so medical. A reminder that our bodies create these strange, specific patterns.
Absolutely. The body tells the story if you just know the language.
Thanks for joining us on this deep dive. We'll never look at a sneeze the same way again. Catch you next time.